Hi, good evening. Recording Respiratory Lecture Part 2 for EMS 240. And going to be kind of short, just a very few slides. Just want to remind you of what we're covering. So our learning objectives for today, we're going to describe the causes, complications, signs and symptoms, and pre-hospital management of patients diagnosed with obstructive airway disease, pneumonia, adult respiratory distress, pulmonary thromboembolism, upper respiratory infections, spontaneous pneumo, hyperventilation syndrome, and some neoplasm. We're going to touch on that just a little bit. So just want to remind you, the primary assessment is going to be the best thing you can do when you have a respiratory patient. We want to look at our patients who are having respiratory distress need to have a thorough assessment. You need to look at their airway for patency. You also need to look at their work of breathing. As part of your primary assessment, you need to take a minute and just look at your patient's respiratory effort and their overall appearance. This will give you a better sense of whether your patient's sick or not sick. In your initial approach to your patient, look at the way they're sitting. Are they in the tripod position? A patient who's sitting straight, leaning forward on tripod position, is probably air hungry. So that's probably going to be a sick patient. Look at the rate and depth of the respiratory effort. Rapid shallow breathing means they're having labored breathing. Accessory muscles are being used, and your patient's got air hunger. If they're speaking in 1 or 2 word sentences, then that means they're sick. The first thing you need to do is give them supplemental oxygen, and maybe they need a little bit of ventilatory assistance. Definitely listen to your lung sounds and focus your attention on a rapid but thorough assessment. This is not the time to be skipping steps. Your initial priority is to make sure you have a patent airway. You know, if they're speaking, then they're moving air. May not be adequate air, but it'll tell you whether or not the airway is patent. If you've got mucus or other secretions in the upper airway, then obviously you'll need to suction that out. Keep in mind every second that you're applying suction is a second that that patient is not able to get oxygen. So balance out the need to clear the airway with the need to give oxygen and limit the length of time suction is applied. Most of the literature you're going to find is going to tell you to limit that to about 15 seconds per suction attempt. So you're going to have to gauge that by your patient. It's okay to give supplemental oxygen. Give it to them quickly, especially if they complain of difficulty breathing. If your patient's not breathing on their own, you need to assist their ventilations. 10 to 12 breaths a minute, 1 breath every 6 seconds is adequate. Watch your chest wall on your patient. Chest wall movement with respiratory effort does not mean that the air is actually moving in and out of the lungs. You need to auscultate to find out if that's occurring. Auscultation needs to be part of your primary assessment, and it is going to help you decide between a sick and not sick patient. In your primary assessment, you're just listening to be sure that lung sounds are present on each side of the chest. This means if a lung has collapsed, you're not going to hear anything on the side of the collapse. You want to hear clear, equal, bilateral lung sounds. You want to have good tidal volume. You don't want your patient using accessory muscles. Now this is a picture of what an asthma alveoli looks like. Okay, so we've got the bronchi coming down. We've got mucus plugs in the bronchioles. We've got hyperinflation of the alveoli, mucal secretions. We've got degranulation of cells, which means these are injured cells and the body's trying to repair the holes in the cells. So what we've got going on in asthma with this photo, asthma is a chronic inflammatory disorder. There are susceptible people out there to asthma, and in those people, this inflammation will cause recurrent episodes of wheezing. It'll cause breathlessness, it causes chest tightness, and it causes coughing. And coughing is the normal response to try to get this mucus out. It's worse in the evening and early in the morning, and a lot of times asthma episodes are associated with airflow obstruction, and it can also be associated with bronchospasms. So there's been some recent research that shows that the common factor influencing lungs and causing the symptoms that a patient experiences is inflammation. So the inflammation stimulated by a lot of variables in the environment. So if a patient is around something that causes tissue inflammation, they're likely to have an asthma attack. Among all of your obstructive respiratory problems, asthma is the most reversible, and it's the most treatable for us in the pre-hospital world. So one nebulizer treatment for an asthma patient also a lot of times makes a great difference. It's important to remember that your pre-hospital treatment revolves around alleviating symptoms and alleviating a bronchospasm. So in the pre-hospital realm, we generally don't address the root of the problem, which is the inflammation. So it's important to remember that patients with moderate or severe problems need to be transported for further evaluation and treatment. So I don't know if you knew this or not, but I'm going to give you the epidemiology of asthma. So the most recent statistics that came out say that about 8% of all the population in the United States have asthma, and that's about 15 million people. Death rates for asthma are consistently highest among the African American population ages 15 to 24 years old, and that has increased in the last 10 years. Multiple factors contribute to that, including poverty, lack of access to medical care, and lack of patient and provider recognition for an acute asthma episode. So that's your updated statistics for asthma. Now, with the physiology, how does asthma affect the tissue, the pathophysiology of it? So normal lung tissue has a complex structure and it has a complex function. Your bronchial passages are lined with epithelial cells, the smooth cells, and also with cilia, the tiny little hairs, and also mucus-producing cells. So when you get things like smoke embedded in the cilia, it lines the airway, the movement of the mucus gets thicker, it invokes the cough reflex, and then what you're going to notice in your, say for example, your patient is a smoker. So these particulates are caught up in the cilia, which makes the mucus thicker, which is going to cause the smoking patient to start to cough to try to get the mucus out. And the pathophysiology in this case means that smokers are at a greater risk for getting infections and for having the inflammation, the tissue inflammation process than a non-smoker. Also present in the airways are a lot of other cells that when inflammation is present, these proteins and immunoglobulins and other things, they enhance the inflammatory response of the lung and they act as a stimulus. Your autonomic nervous system plays a role in the lung's response to inflammation. So your parasympathetic fibers and your vagus nerve innervate the trachea and the bronchioles. So stimulation of the vagus nerve will produce bronchoconstriction in the airways, and it will increase mucus secretions. And that also causes vasodilation. So just a couple of things to think about. In your acute asthma patients, we have an inflammatory mediator, histamine, which is released. Airways are hypersensitive to the presence of a lot of stimuli, but histamine is the most common. You have antigens that are present. And in the early phases of asthma, you have hyperresponsiveness, which is basically an exaggerated acute bronchoconstriction response. It limits the airflow, and that's what causes the wheezing that you may hear when you assess your patient. At the early stage, at the acute initial stage of asthma, in the first minutes to first few hours, asthma is the most reversible when it's treated with a beta agonist, a beta 2 agonist. So you give your patient a nebulizer treatment. As the inflammation progresses, pulmonary vessels begin to leak fluid, and it causes airway swelling, and then mucus is secreted, and it becomes thick to the point of causing mucus plugs. And both airway swelling and mucus plugs combine to cause the bronchial obstruction. Then you're going to notice some clinical signs of late asthma, and that occurs within a few hours to days or even weeks after the first attack. Patient may not clear his respiratory distress and wheezing with treatments, and your patient may have only a minimal or partial response to nebulizers. So the longer you wait, the less likely the patient is going to be receptive to treatments. Another problem you might find in obstructive diseases is air trapping. During a bronchospasm, your patient will probably have trouble moving air in and out of his lungs. And since inhalation is an active process where your chest wall expands and your diaphragm contracts, exhalation is a passive process, and this is relaxation of the chest. So your asthmatic patient will be more likely to be able to draw air in, but not have an easy time getting the air out. So it becomes trapped, the air remains in the lungs, and it's more difficult to exhale when the narrowed airways don't let air flow out. Exhalation is less powerful than inhalation. So with your asthma patient, your goal is to try to reverse the respiratory insufficiency. Try to keep your patient from getting tired from trying to breathe. If your patient has mild exacerbation, then they're short of breath. Typically, they'll be able to speak in full sentences and they can lay down and relax. But patients with a severe episode, they're setting up, they're in tripod position, they can only speak 2 to 3 word sentences. When you listen to the lungs, you're going to hear rales, which is wet, or rhonchi, which is a dry rub, or you're going to hear asthma wheezing. They also may have a pneumonia infection if it's an acute attack. They may have an altered level of consciousness. They may be sweating, maybe tachycardic and tachypnic. You know, those short, rapid breaths that are not allowing for good gas exchange. But an ominous sign that'll tell you that your patient is in impending respiratory failure is when your patient complains of shortness of breath but has a normal respiratory rate, or they have a quiet lung exam with very few wheezes. That's an ominous sign. If they're noisy, they're fighting. When they get quiet, get scared. A patient with an acute asthma attack should have an increased respiratory rate. A normal respiratory rate should tell you that the patient's getting tired and fixing to go into respiratory arrest. By the same token, a quiet chest with very few wheezes suggests that your patient is getting tired and not moving adequate amounts of air. So if your patient has altered mental status, Then they've got inadequate oxygen delivery going on, and we need to reverse that. Altered meditation can compromise your airway patency. It can also, cease respiratory efforts. So ventilatory support with 100% oxygen is necessary. You may need to consider intubating your patient. And I want to talk to you a little bit about something called controlled hypoventilation or permissive hypercapnia. So later on in the lecture, we will definitely pick that up. There's a proper way to do that. And the reason why you would do controlled hypoventilation or permissive hypercapnia is to slow the ventilation rate to allow for exhale time. Ventilation forces air into the lungs, but exhale still depends on passive relaxation of the chest. If air is being trapped by a constricted airway, longer expiratory phase is totally necessary to allow as much emptying of the lungs as possible. Too much air trapping in the lungs leads to a pneumothorax, so you need to be careful to reassess your patients. Okay, so let me back up. So treatment of asthma, let me back up here to this slide. Treatment of asthma is maintain oxygenation, treat the bronchospasms by using a beta-2 agonist, and give them corticosteroids to decrease the inflammation. Now, you remember, corticosteroids are not going to work for you in the pre-hospital setting, but by the time they get to the hospital, they'll start to improve, and you may miss out on the thanks, but you know that you've given them something that's going to help. It's like we said, inflammation is the root of the problem in asthma. Okay, so this is a patient who has COPD. So chronic obstructive pulmonary disease has several different sets of problems. Emphysema and chronic bronchitis are the two main ones that most people talk about. So some people will even throw asthma in there as a COPD illness, but a more common definition excludes asthma. So for purposes of today's lecture, we're going to call it anything other than asthma that causes trouble breathing, mucus production, airflow limitation, and impaired gas exchange, which means we're going to stick with bronchitis and emphysema. Chronic bronchitis is chronic sputum production that leads to airway inflammation in the bronchioles. Emphysema is not the same as chronic bronchitis. Emphysema is airway collapse and destruction of lung tissue starting at the alveoli. So when you compare these things, asthma is the most reversible, while COPD is more chronic, progressive disease, which is less reversible. So asthma would be more of an acute issue. Of these two diseases, emphysema and chronic bronchitis, patients rarely have just one, but commonly have features of both diseases. So we just call it COPD. COPD and asthma should be thought of as overlapping zones, and your patient can fall into one of 7 zones with this particular configuration. So if you look at a Venn diagram, which would be 3 bubbles, one of them emphysema, one of them asthma, and one of them chronic bronchitis, the points with where they overlap, that would be your patient displaying characteristics of all 3 disease processes. So patients who have chronic bronchitis are chronically short of breath, and they have a decreased capacity to exchange oxygen and carbon dioxide. The reason is they have a ventilation perfusion mismatch. So when these patients have acute episodes of trouble breathing, they're probably going to look ashy or they're going to look cyanotic. So chronic bronchitis, we used to call that a blue bloater. I don't like using that term, especially now that we know that your patient will, if they have bronchitis, also maybe they're displaying some emphysema and they may have an acute asthma attack. But typically, your bronchitis patients, we refer to them as blue bloater. Emphysema, though, is characterized by destruction in the alveoli, where either the walls get thinner and enlarged, and following this destruction, then the alveoli will collapse, and that leads to further damage and less gas exchange. And this destruction, tissue cell destruction, is not reversible. So what's going to happen in your emphysema patient? Also, I need to mention, with your emphysema patients, they're going to have these little sores in their damaged alveoli, and these are called blebs. They're little infection pockets. So with emphysema, gas exchange worsens because you lose surface area between the alveoli and the capillaries, which means you have less place for gas exchange. So when your patient gets chronically hypoxic, your body will attempt to compensate for that by increasing red blood cells to carry more oxygen. So your body actually creates something called polycythemia, which means the body's tissues are starving for oxygen. They know the lungs are working, air is coming in, so they're creating more red blood cells, more hemoglobin to carry this oxygen. What that does is make the blood thicker. You have an increase in red blood cells, so the blood becomes thicker. And this causes your emphysema patient to have pink tissue, pinker, redder tissue, so they're called pink puffers. So remember, bronchitis is a blue bloater, emphysema is a pink puffer. It's because you have an increase in red blood cells in your emphysema patients, and it gives them a pink skin tone. So moving on to the epidemiology here of COPD. COPD affects about 14 million people in the United States, and it is the fourth leading cause of death, with mortality rate of 50% in 10 years after the diagnosis. So most people who are diagnosed with COPD have about 10 years left. Their clock is ticking. Primary cause of COPD, no surprise here, tobacco use. But about 10% of people with COPD have never smoked a day in their life. And those people would have environmental and occupational causes for their COPD. Working in a factory, say, for example, a sewing factory around a bunch of lint and dye. And no surprise here, mortality for men with COPD is starting to level out, but the mortality for women is on the climb. And the way COPD works, the pathophysiology of the disease. So first, we know that there are physiologic changes in the bronchi. Two predominant changes. We have inflammation of the lining of the bronchi, and we have an increased secretion of mucus. And the combination of these two things causes an obstruction in the bronchi. It gets worse because of acute viral and bacterial infections, and as the disease progresses, then your patient has trouble breathing on exertion, has hypoxia, has a buildup of CO2, and during this time, bone marrow is going to respond to the hypoxia. They're going to produce more red blood cells to the point that you have polycythemia. So then moving on down, your patient with chronic bronchitis, though, your blue bloater, will have a chronically elevated CO2 level, and that results in abolishment of normal chemoreceptor sensitivity. This is, your blue bloaters are on what's called a hypoxic drive. So the primary drive for respiration comes from the oxygen concentration normally. Patient with chronic bronchitis has a minor risk for medically applied oxygen therapy to suppress the internal drive to breathe. So what this means is, despite hypoxic drive, your patient should never be withheld from oxygen. Always give your patient oxygen if they need it. So here's a little thing that's nice for you to know. Imagine your normal alveoli to be a bushel of grapes, and during emphysema, the grapes are destroyed and they're replaced by a blob of tissue that looks more like a nebulous cloud. There's much less surface area for blood cells to pass through and exchange oxygen and carbon dioxide in that little nebulous cloud than there would be in that bushel of grapes. And along with you treating your COPD patient, there are a lot of things that challenge us with a COPD patient. So your goal for treatment is going to be try to improve their initial presentation, and you're going to want to apply oxygen. Your COPD patients are usually going to have an abnormal baseline for oxygen, and what that also means is probably going to have an abnormal end-tidal CO2 reading as well. So absolute goal for oxygen therapy for acute exacerbation should be a partial oxygen of greater than 60 millimeters of mercury with an SpO2 greater than 90%. That's what you're aiming for. A PaO2 of greater than 60 and an SpO2 of greater than 90. Relatively, these goals include improvement in oxygen saturation from your baseline. And in this way, even your chronic bronchitis patient with a hypoxic drive to breathe should be treated with oxygen for trouble breathing. Providers should always monitor their patient's mental status closely. You providers, you go out, you notice if your patient has an altered mental status, definitely they need oxygen. That is the key indicator. So outside of oxygen treatment, you can also use a beta-2 agonist. Albuterol is a good treatment to give to your COPD patients. But remember, if they're in severe distress, they're probably not going to be able to self-administer the neb, so maybe you want to use the neb mask on them. You can also give them a parasympathetic blocker. Anticholinergic medications are sometimes more effective at treating COPD than a beta agonist. So consider ipratropium. Ipratropium is slower on onset than a beta agonist, so it should be given secondary to a beta agonist. Unlike albuterol, it's a one and done deal in the pre-hospital setting. So you can give albuterol as many times as necessary, but the ipratropium, you give it just once. So I know some of you work for EMS agencies that carry duo nebs. So albuterol and ipratropium are the two components that make up a duo neb. When you give a duo neb, there's no additional fluid needed. You just open it, dump it in the neb mask, and then administer that to the patient. If you need to administer a second dose, that's probably when you just go straight to albuterol. Okay. Also remember in your COPD patients that they get tired easy. Patients have already been treated aggressively with oxygen. You give them a nebulizer. O2 sat's probably going to fall below 90% despite giving these treatments. And alternatively, if following the treatment, your end-tidal CO2 starts to rise above 45 millimeters of mercury, this may tell you that the patient is still having respiratory insufficiency. When you pair that with your patient getting tired, that means it's time to look at ventilation and maybe intubation. If your patient can follow commands, then maybe try CPAP. If your patient is not following commands, you may have to be more aggressive. So just remember, your COPD patients are more difficult to treat and less responsive when you compare them to your asthma patient. So despite the difference in responsiveness to therapy, your COPD patient should be treated with oxygen, give them beta agonists, give them ipratropium, and transport them to the ER. Not going to hurt also to consider corticosteroid in the field. I know it takes an hour to kick in, but your patient will appreciate it eventually. So we're talking about pulmonary embolism here. So epidemiology for pulmonary embolism, about 2 people per 1,000 in the United States get a pulmonary emboli. Typically, your patients are going to present with shortness of breath, chest pain, tachycardia, and a fast respiratory rate. And it's hard to diagnose pulmonary embolism in the field, and it's one of the most commonly missed things with regard to respiratory distress. You can look for things like patient have a history of a DVT, patient been traveling a lot, they've been sitting a long period of time, recently had increased clotting factors. Those types of things can make somebody more susceptible to a PE. But there are 3 basic mechanisms underlying a PE that you need to look for. Stasis of blood, an increased likelihood of clotting, or an injury to the inner lining of a blood vessel, like if they have high cholesterol and they have plaque break loose. Okay? So risk factors associated with the pooling of blood include immobilization in a hospital or in a nursing home, a lower extremity fracture. Cancers can increase hypercoagulability. So when you do your primary patient assessment, you look for these, factors if you're considering a pulmonary embolism. So vital signs for a patient who has a PE, like I said, quick respiratory rate, fast heart rate, pulse greater than 100, SpO2 less than 95%. Those things mean it's highly likely that your patient has pulmonary embolism. So, especially if they have a swollen, tender leg, or if you think that there's something that indicates, are they having chest pain? Have they been immobile? Now, how do you treat a PE? Well, you need to get them to the hospital. You're not going to remove that clot in the ambulance. So the most important thing is recognize that they have some risk factors and they're presenting in a certain way. Transport to the hospital. Give them supplemental oxygen. Try to keep O2 sat above 95%. If you can get an IV, get an IV. Maintain their vital signs. That's your primary goal. So typically where a PE will lodge is in the main branch between the 2 pulmonary arteries, and that's called a saddle embolus. That's the clinical term, saddle embolus. And that embolus can obstruct blood flow to both lungs, and by doing that, it prevents any oxygen from getting into the lungs, any oxygenated blood from getting into the lungs. So because of this, your patient can get severe hypotension, also can get hypoxia. Typically, what's going to happen when you get your patient to the hospital is they're going to get a fibrinolytic like TPA as soon as it's verified that, yes, they do indeed have a PE. And how do they identify that? By imaging. And imaging is not something that we're able to do in the hospital. But there again, our high index of suspicion is going to alert the receiving facility that they need to get this rolling pretty quickly. Now, moving on to pneumonia. So pneumonia is a lower airway infection. About 4 million people a year in the United States will get pneumonia. About 15% of those people are going to be put in the hospital. If you like to keep up with statistics, people that die from the flu, typically the majority of those people that die from the flu virus actually die from pneumonia complications that they have contracted while they have the flu. So for certain populations, pneumonia will cause a significant illness and can cause death. So your people that are already immunocompromised, if they get pneumonia, they can die. So you can get pneumonia 3 different ways. It can be viral, bacterial, or fungal. You can also get parasitic pneumonia. So I didn't put that on the slide, but yeah, 4 ways. Viral pneumonia, fungal pneumonia, bacterial pneumonia, and now parasitic pneumonia. So when you do your assessment on your patient, typically your pneumonia patient is going to have a productive cough with a yellow-green color of sputum. It could be blood-streaked if they've been coughing a lot. It's not uncommon to have some capillary rupture and have some blood-tinged sputum. They'll probably have a fever and chills, shortness of breath, tachycardia, tachypnea, and they're going to be sick. So here's what we need to do. All patients need to be evaluated, get a good set of vital signs, get an SpO2, get a non-invasive end-tidal CO2, which is that nasal cannula type end-tidal. Any patient that's hypoxic or hypercarbic, which is an end-tidal greater than 45, treat them aggressively. Get them oxygen. Either nasal cannula or a face mask. Try to keep their SpO2 at 94% unless patient's got COPD, in which case you want to keep it lower, maybe around 90%. If your patient has associated wheezing, it's okay to give them albuterol. There again, monitor the vital signs. You provide a treatment, get a new set of vital signs. If the patient's improving, keep going on that track. If the patient's getting worse, then try something different. It's okay to start an IV and give them some fluids, KVO, especially if they have a fever, because they could be dehydrated from the fever. An increase in temperature burns off sugars and fluids, and transport them to the hospital. With a spontaneous pneumothorax, we divide that into 2 categories. We have a primary spontaneous pneumo, which means it happened for no apparent reason. And then we have a secondary spontaneous pneumo, which means patient's got an underlying lung disease, and this is why it's occurred. Typically, it will occur more commonly in men compared to women, and men who smoke versus non-smokers. Patients who have a connective tissue disease like Marfan syndrome are more likely to develop a spontaneous pneumothorax. So keep that in mind. Patients with a spontaneous pneumo are going to experience typically a sudden onset of one-sided chest pain. Going to be a sharp pain. It's going to hurt worse when they take an inhale, so we call it pleuritic pain. It hurts worse with deep breathing and coughing. So following that initial onset, there's probably going to be a persistent, deep, aching pain. And, you know, people may put that off for a day or two. In addition to that pain, patient's going to have tachypnea, and when you auscultate, you're probably going to hear decreased breath sounds. You may have some resonance when you do a percussion on the chest. So how do we treat a spontaneous pneumo? Well, get them on supplemental oxygen, because if they have a pneumothorax, they have less area for gas exchange, so we need to make sure all their hemoglobin is carrying oxygen molecules at full capacity. If it gets to the point that there are signs of attention pneumo, JVD, hypertension, hemodynamic compromise, then maybe we need to consider needle decompression. So if our patient is symptomatic, we treat them. If your patient's intubated, for example, if you have a COPD patient who had COPD exacerbation, you had to intubate them, and you've been providing positive pressure ventilation, it is within reason to think that your patient can have a tension pneumothorax. So just because you've got them intubated and they're being ventilated doesn't mean that assessment stops. You need to continue assessing your patient. If you notice decreased lung sounds or absent lung sounds on one side, could have spontaneous pneumothorax. So, moving on, acute respiratory distress syndrome. This is a group of symptoms and signs that occur together lacking a single pathophysiologic cause. We just call it ARDS. It's non-cardiogenic pulmonary edema caused by damage to the lung from a whole plethora of illnesses and injuries. So the common threads here mean your patient's going to be hypoxemic respiratory failure. Their partial pressure of oxygen is going to be less than 60 millimeters of mercury. And they may have one of these cofactors, which would be congestive heart failure, fluid overload, or chronic lung disease. How do you treat ARDS? Well, primarily supportive care. If your patient develops respiratory failure, they're not responding to anything that you've tried, supplemental oxygen, and you need to go ahead and intubate them. Do positive pressure ventilation. You want to maintain oxygen saturation again above 90%. So ventilation pressures are high, so controlled hypoventilation can be used to minimize any barotrauma that your patient could experience. And most cases of ARDS will take hours to days to become clinically severe. So by the time somebody calls 911 and you get there, your patient's going to be sick. With the upper respiratory infection, typically these are not a true life threat. It's only in rare cases. So typically it's either going to be viral or bacterial when you have a respiratory infection. So here's kind of the breakdown on that. With a virus, once the virus establishes itself on the mucous membranes in the nose and in the mouth, then you're going to get the infection. Then there's going to be inflammation, which means we have increased secretions. We might have a runny nose, coughing, and hoarseness. Patient might have a low-grade fever, like around 99. Patient's going to be uncomfortable, but they're not going to be life-threateningly sick. Bacterial infections in the upper respiratory system are less common than viral infections, and typically the bacteria like to go to the pharynx or the tonsils. In this way, if the patient gets pharyngitis or tonsillitis, there's usually not a runny nose or a cough. Infection on the tonsils will cause white blood cells to respond, and then you'll get the pus on the back of the tonsils. And so when you do your assessment, you may see the pus on the tonsils when you have them open wide. But like I said, it's usually upper respiratory infections are not a life threat, but they can make things worse. With hyperventilation syndrome, hyperventilation basically is because of a rapid respiratory rate. Patients blowing off too much CO2, and it leads to respiratory alkalosis. So there's a lot of causes for hyperventilation, physical causes, and also anxiety. So how do we treat it? Well, when you have a patient who's hyperventilating, you need to realize that there are a lot of medical causes that cannot be easily identified. Your patient should be assessed and evaluated for a medical cause for hyperventilation. And because there are plenty of medical causes that we cannot rule out in the field, we need to be very careful and evaluate for medical causes first, and don't just assume that it's anxiety. If your patient tells you that their mouth or their fingers are numb or tingling, it's possible that the patient has raised their pH enough to even affect their consciousness. And that's because of the loss of carbon dioxide. See, that's the homeostasis. The body will try to compensate. CO2 is an acid. If we're blowing off too much of that acid, then the body will withhold acid from the kidney, and sometimes withhold so much that it raises the pH balance of the tissues. So with CPAP and BiPAP, first let me back up. I don't want to hit this real quick without talking to you. Well, there it is. Without talking to you about controlled hypoventilation. We called this permissive hypercapnia earlier in the lecture, and I want to hit on it real quick. So controlled hypoventilation is directed at maintaining acceptable oxygen sats while also tolerating a higher CO2 concentration. This allows respiration to continue because oxygen continues to be delivered. Now, normally hypercarbia is not ideal, but it's necessary to allow it to occur because completely removing it or correcting the imbalance is not possible without worsening your patient by creating a positive pressure in the chest. So the actual technique for controlled hypoventilation means you give a high concentration of oxygen to obtain an adequate oxygen saturation above 90% while tolerating a high level of CO2 by using a small tidal volume. So you still give them 100% oxygen, but you use a small tidal volume. And by small, I mean like 8 to 10 milliliters per kilogram. So use a small tidal volume and a slow ventilatory rate. So less than 10 breaths a minute. Okay, that is controlled hypoventilation. And this is a strategy that you can use in an asthma patient or in a COPD patient. It minimizes the risk of barotrauma. It minimizes the risk of hypotension. And some patients do well with it. So now we will move into, well, I want to talk to you about the non-invasive capnography. And I said earlier You can measure your end-tidal CO2 outside of just the ET tube. You can use the nasal cannula capnography. So the way you want to do that, it's important, especially when you're talking about an asthmatic patient, it's important to use the non-invasive. We want them to have an end-tidal CO2 value below 35 millimeters of mercury. It's on the lower limit of normal, so 30 to 35. If we keep it there, your patient's still breathing adequately, but they're not getting tired. Treat the patient aggressively still with your neb treatments and with ipratropium or a dual neb. Monitor their response. If the end-tidal CO2 value is decreasing, then the therapy is working, and keep doing what you're doing. If your end-tidal is rising, then you need to check your patient, see if they're getting tired, see if their breathing is ineffective. And then obviously CPAP and BiPAP are things that we can use. So CPAP has a lot of benefits to your patient in respiratory failure. So the intended effect is to deliver air with an adequate concentration of oxygen. And what that does is increase the pressure in the alveoli, and that results in an increase in the volume of gas in the lungs, which means we have better gas exchange. It's supposed to decrease your patient's work of breathing. So it's especially effective in pulmonary edema, because in pulmonary edema, your alveoli are not functioning because there's fluid in the way. So the CPAP pushes that fluid out. It reverses the pressure gradient, and it encourages fluid to move back toward the interstitial space near the capillaries. So with a BiPAP, it works similarly to CPAP, but it's just a little bit different. So your patients who have respiratory insufficiency, with BiPAP, it allows you to set a separate level of inspiratory pressure versus expiratory pressure. So it's bi-level. And now finally taking you to the summary of this part 2 of the respiratory lecture. So respiratory distress is one of the most common reasons that we get called. A lot of times your primary survey is going to show you life-threatening breathing problems that are going to require rapid intervention before you have a thorough understanding of the disease process or what's really going on with your patient. So determining the actual cause of the breathing problem is not as important as performing an appropriate patient assessment and getting a thorough history. From this, your treatment decision can be made, and that'll enable you to properly care for your patient. Remember these points. Respiration involves the delivery of oxygen to tissues. Ventilation involves the removal of carbon dioxide from the body. And some chronic respiratory diseases cause abnormal CO2 levels, which may not require treatment, provided your oxygen level is adequate. A patient with chronic lung disease switches to trigger the breath from hypoxic drive and acidic levels, pH levels, instead of oxygen levels. And maintaining your patient in a well-oxygenated but also slightly hypercarbic state may be necessary in order to minimize disruption to cardiac output. So I'm going to leave you now with a quote. This is Aretaeus the Cappadocian. He was born in 81 AD. He died in 138 AD. And he studied the writings of Hippocrates, which was who we refer to as the father of modern medicine. Aretaeus said this: animals live by two principal things, food and breath. Of these, by far, the most important is the respiration. For if it be stopped, the man will not endure long, but immediately dies. funny little thing about Areteus, he studied Hippocrates, like I said, but Hippocrates believed that the natural response of the body was the best response. Areteus disagreed. He believed that sometimes the natural response of the body was just as harmful as the problem occurring. He was an interesting man. He was the first person to write about seizure activity and uterine cancer. So I would encourage you to try to study a little bit about him. And I will end the lecture now, and you will be able to download this lecture later and listen to it as often as you need to.